Hey, chiropractors, welcome to Modern Chiropractic Mastery with your host, Dr. Kevin Christie, where we discuss the latest in marketing, business, and professional growth with some of the leading experts in the industry. Docs, welcome to another episode of Modern Chiropractic Mastery. This is our MPI mini-series on being world-class at treating athletes. This is part 4 of 4, and this is with Dr. Brett Winchester, and we're going to dive into a lot of information on return to sport guidelines and time frames and really diving into it from a clinician standpoint, someone with a lot of experience, not just your typical guidelines you would read in a book for an injury. And as you'll hear, there's a lot of context that needs to go into making these decisions. And we probably could have had an 8-hour podcast on this or a course on it, but we dove in. We got into it pretty quickly and really touched on a couple key components and then some ancillary aspects. And we even talk about particular conditions, the ankle, the elbow, and really give you a good starting point to start getting better at this if you feel like it's a blind spot for you. Even if you're seasoned chiropractor, been doing this for a while, Dr. Winchester brings a lot of experience and knowledge to this podcast, and we're excited about that. Before we get to it, we do have the MPI Master Series Sports Summit, which will be all about the lumbar spine, and that's going to be in Overland Park, Kansas, March 25th and 26th. Got quite a lineup. We're going to have Mark King, Corey Campbell, Brett Winchester, Jason Ulm, David Seaman, and Rich Ulm to dive into all things spine. It's not just going to be palpation, it's going to be that. It's going to be soft tissue and rehab and nutrition, assessments. So, a lot of what we talk about in this episode will really be distilled down into the spine for this particular seminar. I'll be there, excited for it. First time back since COVID had canceled the last few. And so hopefully you'll join us there. Again, that's March 25th and 26th. You can go to motionpalpation.org, click on the seminars tab, and you can register right there. Without further ado, here's my interview with Dr. Brett Winchester. All right. Welcome to the show, Brett. I really appreciate your time today for this MPI being world class at treating athletes. And we're going to really dive into something that's specific and for a lot of people takes a lot of time to cultivate, but that is getting confident in return to play / return to sport guidelines and just overall clinical decision making. So welcome to the show today.
Thank you, Kevin. It's wonderful to be here, of course.
Yeah, so it could be a thorny topic, and there's a lot of different nuances to it, obviously. But let's start from the perspective of we're going to just talk about any athlete in general, but then sometimes you'll give us some, some context. If it's a pro athlete, you might have agents dive into this whole equation, and there's a lot of different people that play a role in that. But let's, for the sake of our general conversation, we'll just say we're dealing with high school athletes. Maybe it's college, maybe it's NFL, whatever. But what are some of your overarching thoughts on clinically getting really good at understanding how to make that determination on that athlete's time frame?
Yeah, I think I'd probably start the conversation, Kevin, with what I tell my patients, which is I didn't gain my reputation by resting my athletes. So, you're on the razor's edge of, you're going to have, the orthopedic model, which is going to be, rest, immobility, typically that thought. And then you have like the world that you and I are in, which is we're kind of pushing the limits and, creating our reputations for getting our athletes back on the field. So I think that's like a really important initial point is we got to have context to the injury. For example, if you're high school athlete, it's the second game of the season, you have a high ankle sprain, you're out a month, literally. I mean, there's no way around it. And even now there's surgical repair that we do to get you back in a month. Patrick Mahomes, he's got to play this weekend, So, I mean, there's a difference in context because, this is potentially one of the biggest games of Patrick Mahomes' life. So, the risk benefit ratio is there. And I mean, if we're talking about the high school athlete, that can also play out because you may have, the state championship wrestling matches tomorrow. You have a fractured fibula well, I can get you ready to still be able to wrestle tomorrow. I wouldn't do that if you were 8 years old, and I wouldn't do it if it weren't the state championship. But I think like you got to first just take a step back and say, is the risk going to be worth the benefit? That's like the first question to ask yourself. And then I think the other thing is, you have so many different people that are involved. And a lot of times you'll actually have more pressure from a dad of an 8-year-old son than you will a professional athlete. And the reason is because if you have a sore elbow in professional baseball, especially with the length of the season, you're on the 15-day IL, no questions asked. I mean, if you take that and then you apply it to your little leaguer who's got a sore medial elbow, and you have dumbass dad there who's saying, "Oh, he's got to play. He's got to pitch Wednesday." No, he doesn't. Like he does not need to pitch Wednesday. And I always bring it back to like professional baseball, where I say, if your son right now is a professional athlete, we would shut him down for 2 weeks, no questions asked. That doesn't mean we're not doing therapy and rehab. Of course, he's there every other day getting all those things done with the latest and greatest technologies that we all know. But we also have a brain to know that, rest is important with these injuries. So you got to have context of the injury, and you got to understand the risk benefit ratio. And then, like you said, and I think this is a really good point, it's got to come with conviction. So, I mean, you have to say it, and you can't be wavering on it. You literally, if you don't think they should play, you need to tell it like you cannot play, because really what you're trying to tug on the heartstrings of the parents a little bit and make it seem like that they are insane for letting their son or daughter play in 2 days. Like it just doesn't make any sense. So that way you take it off the table, and that's not even an option. And it literally has taken me 20 years to get to this point. But I mean, if I could tell myself as a younger clinician, that would be one of the things when something's right, you got to come at it with a lot of certainty.
Yeah, and I wanna touch on that a little bit on both ends. It can be very tricky with the parents, and hopefully this conversation you and I have can speed up the younger clinicians' conviction a little bit and have that direct conversation with the parent. And because it's tricky too, because the parent typically is obviously making the decision in that standpoint. It's one person, maybe 2, maybe the 2 parents are gonna, have that communication on it, but a lot of times you'll find one parent is the decision making as far as the athletics goes, right? And so
Or
there's
the
just
parents are divorced or separated, and that can add like a completely wrinkle, to it also.
that's a whole other level of context for sure.
Yeah.
So you have that, and then I always look back in like 2014. We'll go on the other end of the spectrum with professional sports. So I had an opportunity to treat a top 5 golfer down at the Doral event. They brought me in for neck stuff, but he also had this thumb thing, and I had nothing to do with the thumb thing other than, I was privy to the whole process of his team making decision. And the next, 2 weeks from that Doral tournament, this was back when it was, organized this way, schedule-wise, was the Masters. And, I mean, they took him out to the driving range, they evaluated. We sat down with, like, his agent, his swing coach, his performance coach. I happened to be able to hang out there. It was him, his wife, and he hit some balls. He felt pretty good. He was off a little bit. The context was he decided to shut it down at the Doral and not play because he wanted to get prepared for the Masters. Now, if it would have been the Masters, he would have played, right? So that's your point of the context is there's a lot to it for sure.
Right. And then I think too, I mean, if we're dealing with like professional athletes, there's so many business decisions that come in play. So I learned from one of the orthopedists for the Cardinals, who I think is one of the best in the world of what we're talking about, which is, when you understand soft tissue injury, being able to tell the team like what this injury actually looks like instead of just guessing, and the higher level they are, that's where like MRIs and, maybe ultrasound really helps us guide, an organization or even like the parent to let them know that, this is a 2 week injury or this is a 4 week injury. This is what you should expect. And I think what a parent wants to hear, they want to hear what the plan is. And they also want to be getting an update along the way. So at 1 week, they want to know, is my son or daughter, are they hitting their marks for 1 week? Is everything going the way that we want? And then if things aren't going the way that we want, I think they're okay with that as long as you kept them educated. The problem is when you're at your timeline and you haven't educated them well, and then they think their kid is ready to play and they're actually not ready to play. And then you get stuck. So, I mean, I think a pretty good way to sum up the topic we're talking about right now would just be maybe to be safe, especially early on, you could overestimate how long the injury is going to potentially take. That way, if you're outdoing your parameters, then we can get the athlete back. And that happens all the time. I mean, even in physical therapy where, I mean, and I don't think this is right. And James Andrews will say, he tries to talk all his ACL repairs to waiting a year to get back to play. But I mean, we have kids getting back to 6 months, 6 to 8 months after ACL. So, I mean, that opens up a new discussion of, are they truly ready to play? And, does it make sense for them to play? If they're the star, female soccer player in the area, they're going to college, but oh, by the way, just for fun, they're playing basketball. I don't think it's worth the risk to play basketball, especially if they're getting a scholarship for soccer. That's not the cool thing to say now, because the cool thing to say is, sports specialization, where my son or daughter's playing 8 different sports. And the one thing I've learned about sports, if you want to go somewhere in your sport, you need to be playing that particular sport a lot. But the cool thing now is to say that, that we play 3 and 4 different sports, which when you're young, I think that's important. But then real quickly, you're going to see that you're going to need to somewhat specialize into your sport, unless you're just like a freak that is able to be all state at everything. But that is 0.001% of the population.
Yeah, I mean, you don't even see the Bo Jacksons of Deion Sanders anymore in professional sports. Like, Kyler Murray, they're just like, no, you're picking one of these things.
Yeah,
you know,
exactly.
you can't
But I
do
think
both.
also, I mean, what I think chiropractors probably don't do a great job of overall is, if we just look at the original way that we describe tissue injury, which is, we have an inflammatory stage, a repair stage, and a remodeling phase. We don't understand those phases very well. So if you can really wrap your brain around those phases, and everyone's got a different timeline. I mean, a pretty good rule of thumb is the inflammatory stage is 24 to 48 hours. We have interleukin cytokines, we have macrophages, just like that whole tumor necrosis factor. We have all of these things that occur once we injure ourselves. And that is, we basically have to respect that phase. Like there's no doing anything crazy in that first 48 hours. So, and then after that, we get to the repair phase. So that's like, we're starting to, add weight bearing exercise. We're pushing the limits, but we're not ready to get back to the field. And then of course we have that remodeling phase, which is that phase where we're slowly but surely kind of getting them ready to get back on the field. And I think what happens is sometimes our treatment, ironically, puts people back into the inflammatory stage, and we actually are doing that on purpose. So let me give you an example. I would say, like, of the people that are treating athletes, I would say 80% of us are doing some form of, dry needling or acupuncture. When you decide to do that, or when you decide to scrape on things, or, whatever the soft tissue technique is, we are basically saying at that point, we're putting you back into the inflammatory hospital, which is fine. We do that literally on purpose a lot of times. But then we don't educate the athlete or the parents that we are purposely inflaming this tissue
Mm.
to actually create the response that everything I just mentioned with the cytokines, the interleukins, and the growth factors, all of those. And then we need to now be careful in the next 24 hours because we've just purposely created an inflammatory response. Now, why that matters is because if you're the starting pitcher tonight at 7:15, shifting them back into the inflammatory stage at 2 o'clock this afternoon is a horrible idea. And I think I see this mistake. I mean, it's probably the most common mistake I see made in professional athletes across the board, not just baseball, all of them. So really, having the leadership to kind of understand, you're in charge of this case. We're purposely doing this. We educate them that, we would expect you to be sore. In fact, when I tell my athletes, I want you to be sore. Like we have a saying in that first 48 hours, if it hurts, it works. So, we're putting you back in the inflammatory hospital. Then, at 48 hours, then we're starting the repair phase. And that stage looks a little bit different. And then the remodeling phase looks different. And what the evidence-based group is going to want to hear because they're so guilty of under treating their athletes. And I mean, and I'm not saying this from a business standpoint, but I'm kind of as a business standpoint.
Mhm.
You have, at least 4 to 6 weeks of treatment that should be done on these athletes. So I would say that a majority of people, just because they're such ethical, awesome humans that are going to be on listening to this, they are grossly, grossly, grossly under treating their athletic injury.
Yeah, and I wanna touch on that a little bit because and I use the analogy a lot of times, like, okay, the NFL player gets hurt, how many times a day and how many times a week do you think they're getting treated, right? Every day, probably twice a day, if not more, of some fashion, right? And it's like, why are they doing that? Because it works, right? It gets them better quicker. They're on timeline, pain reduction, all the things. It works. So then we get the same scenario, except for it's not a pro athlete now, it's a regular, 17-year-old. And we do this like, oh, let's do once or twice a week for a couple weeks, see how it goes. And we're very like wishy-washy on it. And now I get there's finances involved. I get there's travel and time and all those things, but are you actually giving the recommendations that's going to get them return to sport in a timely manner?
And I think too, like conviction, certainty, confidence. That is what in the beginning, honestly, I hate to say this, you just have to fake it until you actually are feeling it, that within yourself to have that conviction. But the parents and the athletes will feed off of your confidence. Like now, and it's taken me a while to get to this point because when I was young, I literally thought that I could fix everybody in 3 visits. And then once I had my epiphany moment when I learned that that's basically not possible. I mean, you have your miracles, don't get me wrong, but the reality of it is these injuries are, they're a little bit of a process. And I actually, one of the most important things Mark King taught me when I was, still in school was a lot of things don't actually have a fix. They need to be managed. And our job is to be there to manage these cases really, really well. And I think where this conversation is headed is, return to play, which means if we get an athlete, we get them out there too soon and they blow up or they're not ready. Well, that's also not going to look great on you. So you want to be sure that you've done your due diligence on the front end. And then that way they're truly actually ready to get back out on the field.
Yeah, and obviously one of the big, huge differentiators you need to make as a clinician is making sure there's no red flags from the injury, right? Like you got to rule out. Let's for the sake of argument, as chiropractors, we've ruled out the derangements, right? Like they didn't tear the ACL, they didn't fracture the whatever. Yeah, like so we've ruled that type of stuff out. Now it's a sprain strain that's going to heal. We can speed that up. We can get it better. We can start to make judgments. Is it a grade one hamstring strain or is it a grade two? Like we can start to really use our clinical judgment and our evaluation process to do that. So we'll use that as our kind of backdrop. We for the rest of this episode is like let's put away the crazy stuff, the stuff that's out of our office, and then they're not playing. Now we got this athlete that's got pain. It's an injury. We have to make the decision. Yeah, you can play. Probably not going to make it worse. You're probably not going to feel 100%. We can get you out there. It's the playoffs or it's towards the end of the season. It's important. What are some of your thoughts around that conversation?
Well, in hearing you talk, I think probably maybe the easiest thing we can do is just pick an injury. So let's pick an inversion ankle sprain, which is the most
Yeah.
common injury that you're going to see in a sports medicine practice. The first thing that we ask the athlete is, "Did you feel a pop?" And the reason that is important is because this has all been looked at from a research standpoint. When people rupture their ATFL or their anterior talofibular ligament, 100% of the time, they actually feel a distinct pop in their ankle. So that is a really, really important question to ask because that's going to have huge effects in the trajectory of that case. So then the next thing would be, okay, if they didn't feel a pop or maybe they did, what is the orthopedic test that we want to do? One thing we've learned about the spine is orthopedic tests are essentially worthless besides like a straight leg raise. Now in the extremities is a little bit different. So in the ankle, you have like an anterior drawer test, for example. So that would tell us the integrity of the ATFL and the other ligament we got to worry about is the calcaneal fibular ligament. We also have like an X-ray criteria. That's called the Ottawa criteria, which is if they have certain tenderness like around the distal fibula, the fifth metatarsal head, there's certain key areas that you can look for if you Google the Ottawa criteria. And that tells you whether or not you'd want to order maybe a plain view x-ray right off the bat. Cause like you said, you certainly do not want to be missing, one of these rare little fractures that we can see. So, then at that point, the next question is, okay, so insurance is in the way. So, we can't just roll out and get an MRI to find out the ATFL is torn. What's my cheaper option? Well, for $150, I can get a diagnostic ultrasound, and that will tell me whether or not the ATFL is ruptured or not. And the reason this matters is if the ATFL is ruptured, usually, at least for the rest of that season, maybe for the rest of their life, if they're on an uneven surface, they are going to require a certain brace. So we use a DonJoy velocity brace, but otherwise they're either going to need to, tape themselves or have a brace for them to probably have the stability that they want. Now, if they're just going to go run out on pavement or asphalt, they're not going to need a brace for that in the future. But that's why, like really early on in that example, I want to know whether or not they actually have a ruptured ATFL. The other thing is if you're 3 days out and an inversion ankle sprain, it's all blown up, it's swelling, it's doing its thing, but you're able to play, you can almost bet the farm that they actually don't have a ruptured ATFL because that injury is also, I mean, that you're looking at the best case scenario on that, like on an ATFL ruptured 3 weeks, and usually it also is about a month to recover from. But I always tell the parents, like, there's two longitudinal studies, and like they found that, whether or not you do surgery, it really doesn't matter on a 2-year follow-up. So, so far, we're not doing surgery to repair that ATFL. But as you can see real quickly here, Kev, like knowing what the exact injury is helps a lot to give advice to the coaches. And that way you're not looking like a buffoon on like the advice that you're giving, because if they have an ATL rupture, they're not playing. If today's Tuesday, they're not playing Thursday. There's no way. So like, don't even, throw that out. In fact, we're probably going to put them in a boot for, 3 to 4 days just to kind of, let them get around and, let that inflammatory stage kind of settle down. So,
Yeah.
uh,
And we've all made that mistake too. I know I have, where sometimes you find you miss something that's going to be a longer time frame of recovery and getting out there. He's like, "Oh yeah, I think they'll be better, in a week or two." And next thing, that week or two comes by, and they're like, they're not ready yet. What happened? Now it's an indictment on your care that you've given. It was a mistake in your diagnosis, but they're going to start blaming your care. It's like, oh, he's not that good at treating this or something like that, right? Like it can really come down on you if you're not getting there. Now, it's never going to be perfect. Some people aren't going to respond like they should, even in perfect scenarios, but you got to get the diagnosis right.
and this is where this goes so different than like general population. I'm so glad we're talking about this because I feel like this is a really important point. If you are going to play in the sandbox of athletics, you want and need imaging because imaging will save your reputation. So, in the world of general population, of course, we have these guidelines. I mean, people are telling us like they need to, like look at Medicare guidelines. You need to fail with, a month of physical therapy before you can even get any imaging. In the athletic world, especially as MRIs are way more cost effective, I can get a lower extremity MRI for $300. So just to save my reputation, I just put it on the patient. I'm like, listen, this is going to determine the next, 4 weeks of care. It's $300. I can, even if you have a high deductible, just pay cash for it. That way we know what we're dealing with. And I can give you way better advice once I see the MRI. And I'll tell you a quick story on this is one of our pitchers. He is, he was, I don't know what year it was, not important, but he's doing a walking piriformis or external rotator stretch, if you can imagine what that would look like. And so he feels this big old distinct pop in the lateral part of his knee. And I'm basically the first one there. It's blowing up. He's got joint line tenderness. He can't squat. He can't duck walk. I'm the first one on the field, and I say, "Yeah, you got a lateral meniscus tear, probably." And then the two orthopedists get there later on that day, and they're like, "Yeah, he has found a way to basically tear his lateral meniscus, and he felt the distinct pop, the whole deal." So we get the MRI. The MRI comes back. The lateral meniscus is literally perfect and pristine, nothing. He's got an acute popliteus tear that you typically only see in dashboard injuries and car accidents. But that's like a perfect example of like in private practice, you would have thought it was a lateral meniscus. You would have treated it conservatively. 3 weeks later, it would have been better and it would have been fine. But when you actually have the imaging, you see, the difference. And in that example, that makes a huge difference because, if you have a lateral meniscus injury, you're in the McKinsey hospital, I'd probably be using directional preference. If you have a acute muscle tear, then you're treating that athlete completely different. So I would be an advocate for, when possible, getting imaging. And I mean, with the advent of the MRI just tells the whole story. So I typically, and I know this goes against a lot of guidelines, in the world of athletics, I usually just a lot of times bypass the x-ray and I just want to go right to the MRI because it will tell me the whole story.
Yeah, because again, you need to know exactly what you're treating. You got to come up with some pretty, you know, distinct timelines for the athlete, for the parents, for the coaches, for the agents, whatever it may be, and having that imaging. And again, even to like you can go to a hamstring strain, you can get imaging of that and know, is it a one or a two? If it's an NFL player and they're coming up on it, it's like, okay, is he missing 1 week or is he missing 4 or 6 weeks? Or like that's important stuff to know.
No, and I think the hamstring injury is a perfect example. Like, I'm not going to say I'm perfect at it, but I bet I could get within 3 days. If you showed me the MRI report by somebody who knows what they're doing, I mean, you could real quickly get a pretty good window of what that injury is going to look like. And I can't believe, I mean, 'cause it's my world, but like UCL is a perfect example of that. Like, kid comes in with medial elbow pain, let's say they're 15 years old, and you're treating conservatively. 1 month later, you find out, well, shit, you had a ruptured UCL this whole time. Like, you just lost 4 weeks, like, so sometimes I think, and I know it's not the cool thing to say, but in the world of sports, the imaging is key. And the other thing, Kev, if they start to, let's just say they cheat on you and they go to the orthopedist, does not trust in your opinion, what's the first thing the orthopedist is going to do?
MRI.
Order the MRI. So then you really, being the low man on the totem pole, being a chiropractor, you really look like a buffoon because they're like, that dumbass chiropractor was treating you. Why didn't they just order the imaging? Like, so it's real quickly for, you'll look like an idiot. So that got done to me one time and I'm like, not anymore. Like, I'm going to get the imaging, even if it's, expensive, because that way I'm going to save my reputation.
Yeah, and we've had a couple of those recently. The teenage baseball elbow, and we sent right out for the MRI, and it came back. And what we talked to the parents about was like, look, we're going to be cautious. Get the MRI now. Hopefully, it shows nothing, but we want to know one way or the other because that's going to be a big determination of how we progress with this. And then if the MRI comes back and it's got a significant issue, a lot of times, and I'd like to get your input on this, kind of be our last little topic in here. At what point do you really start to co-manage with other specialists? Let's say you get that MRI, comes back based on some of the findings. When are you starting to refer and co-manage?
One thing I learned early on is, as long as I can always play well with the people around me, it always goes good for me. And
Mhm.
like with the chiropractor, again, whether you like it or not, I mean, at least when you're young too, you're the low man on the totem pole. But what's interesting, as you start to get your reputation, like, you actually, either in the patient's eyes or even the orthopedist, you actually become the high man on the totem pole. If you can just help yourself early on and not get ahead of yourself. But I think that, you know, when you need advice from somebody because you literally don't know, then get advice. And I think a lot of chiropractors make that mistake. Like, they don't know, and therefore, because they don't know, then they're accruing a lot of liability in the case because they simply don't know. Where if you can just make a relationship with the orthopedist, which they will love you for what I'm about to tell you. I mean, because what they want is they want a gatekeeper like you and me. So the difference between myself and, the local primary care doc is I'm a way better gatekeeper. Meaning, like, if you're the primary care doc and an older patient comes in with knee pain, they send every knee case to the orthopedist, basically. The orthopedists hate that because they don't make any money on that visit, right? So what the orthopedists love about, you and me would be that when we send them to you, they're going to surgery, so you and I become this amazing gatekeeper. But to answer your question, what that means is they also are willing to step in and give advice. Like, in medial elbow, I mean, I got, George Paletta here in St. Louis. If I'm questioning anything at all, I let him look at it and he doesn't mind. He's like, a lot of times he'll just look at the report on the phone or download the image and just basically tell me whether or not it's even worth him seeing.
Mhm. Yeah. Yeah. And that's a great way of building relationships of other providers and having that communication. And early on, especially, don't be afraid to ask them questions and be humble and learn. They're not going to look down on you because like they expect a chiropractor to be able to ask them questions on the elbow. They don't expect us to be the absolute expert. They know they are, quote unquote. And so you asking them particular questions isn't going to say, oh, this chiropractor doesn't know anything. It's
Well, the other thing too, I mean, that is your way when you're young to shed liability. Like so if the case doesn't go well and ends up in surgery, you've at least had the orthopedist get his opinion on it, and then you end up looking good no matter what.
Yeah, yeah, absolutely. What are some overall good resources for getting, other than just trial by fire, but some good resources of getting more information on these types of topics on return to sport and guidelines? And, obviously we touched on the ankle and a little bit on the elbow, hamstring, but there's so many different things. What would you recommend?
I mean, I think like the orthopedic book that the orthopedists always talk about is Derez, DeLee, and Miller. It's three different authors. It's a two-set series. I mean, you would literally go nuts reading this whole book, but because it goes through surgical procedures and things like that, but it also timelines sports injuries really, really well. I think that's an important point. And then, if if an athlete has had a previous injury to date, that's the only thing we really know that's going to predict the next injury. So like it's like I tell our guys with the high school, because we have the contract at our high school. It's like just take their injuries from their career, and that's what we need to be doing specifically for them, because that is really the only known thing that exists that's leaving them susceptible to a future injury. And I think that thought is very underrated also. So knowing what previous injuries they've dealt with is a really good way to prevent future injuries. And then, I mean, everybody's got a different philosophy on like why balance, whether or not or a 6-inch step down. I mean, we'll never solve that problem. But I think having some kind of criteria, and I also think, Kevin, that this is, I think, the most important point that people don't talk about. The biggest mistake that gets made is you've done nothing for 4 weeks. You pass a dark fish or a Y bounce, whatever the assessment is, and then, okay, go play in the game tonight. What's never talked about, but I think is a really critical point, is there's got to be some kind of hybrid between that. Like you've got to, let's just take soccer, for example. You've got to go out in a light scrimmage with, a couple of your friends or your teammates. And that's got to be like part of the process. And then
Mhm.
go a little bit harder in 2 days, go a little bit harder. I mean, it's a lesson in graded exposure. And I think for some reason, we just don't do that very well. Like we go hard on the physical therapy side and then, oh, time to go back to the field. You're ready. Instead, there's got to be graded exposure on the actual athletic field, because what you're going to find, you could go out, and just be knocking a soccer ball around, and you might come back and be like, yeah, I'm not ready. Well,
Mm.
then you're not ready. Whereas, a lot of times it's like, well, the game's tonight, you got to go back out. And I think that would be a really solid piece of advice to your question, because your question really doesn't have a direct answer,
Mm.
because everybody continues to infight on that question.
Yeah, but I think you brought up a great topic is start to learn what graded exposure would be for particular sports. And then also that's a great way of having communication with the coaches and say, hey, look, this is what we're looking at as far as graded exposure into soccer. He needs to be able to give you feedback, vice versa. We need to communicate on this. And ultimately that helps with the decision making process. So I'm glad you brought that
Well, I
up.
mean, we don't want him getting slit tackled, like, so, I mean, maybe we put a yellow shirt on him, but you know, the people around him also need to know that he's trying to come back right now. And people have a really, how binary the world is right now. People just don't do well with, moderation at all. And then I would add one more huge tip to people in sports medicine. When you're dealing with injury, tell the athlete and the parents, use it as a catalyst to get them back. Because in the orthopedic world, they're basically telling them, you tore your UCL, your ACL, kind of your career's in jeopardy now, your livelihood's in jeopardy, your way to make money's in jeopardy, that's your identity. So what I do, and this really has served me well, is, you tore your ACL tonight. This sucks. Let's cry about it tonight. Cause I mean, this is going to wreck your world. But tomorrow when you wake up, let's take the next 6 months of our life. And this is actually going to make you a better athlete. It's just going to be a catalyst to be better than you were before. And how I know you're healed from your injury mentally is because a year from now, you'll look back at your injury and you would say this, Kevin, you would say, I'm glad that I tore my ACL and then I make them fill in the blank for it. Like it was a catalyst for me to come back. And I feel like the really good athletes, they do a really good job internally of doing this. And then like you and I are in a perfect position to just be that voice of confidence for them. Like, yeah, we're pissed off that this happened to you. I'm a competitive human being and they can feel that I'm competitive. Like, let's do this together. From this point forward, here's the plan. When you're about to get down on your injury, just remember you're coming back better than you were before. So there's no bad things in sports injuries. There are only learning moments.
I love it. That's great. I'm excited to run into you at the MPI Sports Summit, Kansas City. It's gonna be all spine related stuff. I'm sure we'll be diving into some of these topics, but all related to the spine, and that'll be a great one. It's been a few years, hasn't it?
Yeah, man, what a crazy couple years. But yeah, we might actually manipulate some people that weekend too, since it's a spine. So that'll be fun. And then yeah, and then we got the new format with the adjustathon. I know you and I have been talking about this, but this year we're gonna really be attracting the docs. So, we've always had, 300 students there, but we're gonna try to, continue to make this just the breeding ground for an MPI. And the seminar for the adjustathon will be separated. So,
Yep.
and I think it's gonna be insane. We're gonna have a college game day set there. I mean, it's gonna be
Yeah,
it's gonna be off the hook. So
it'll
yeah,
be
so those
fun.
are
Actually, I got an email from a young doc who went through all the MPI stuff, and he was emailing me back from the Corey Campbell episode on this series of manipulation in the athlete. And one of his complaints, because Corey and I talked about how when you're in chiropractic school, you're just adjusting other chiropractic students all day long, and that's pretty easy. You get out in the real world, and you got Bob, who's 240 pounds and hasn't moved in 5 years. It's harder to get that manipulation and even the palpation aspect of it. And so this particular Cairo was emailing me. He's like, "Is there any, seminars that are more DC based where we can get our hands on a lot of other DCs and learn from them as well and adjust DCs that are 40 years old and 50 years old, guys like you and I that are harder to adjust now." And so, yeah, we're trying to get that to happen with MPI and really make it to where these DCs that are out in the field start getting back into it and honing that skill set.
well, an interesting happens when you're a student. It's, because everyone's so hypermobile and young, it's harder to palpate, easy to adjust. And then ironically, real quickly, you get into private practice and all of a sudden it's really easy to palpate because you couldn't miss that stiffness if you tried. And then it's harder to adjust because you're not used to adjusting through a cinder block, literally. But
So
uh,
yeah, I'm looking forward to those changes as well. But hey, thanks for your time today. This was great. I know we could do an 8 hour podcast like Joe Rogan style on it, but we'll have to keep it piffy.
yeah, thanks, Kevin, for everything you're doing for MPI in the profession.
I hope you enjoyed this week's episode. And if you want to make the shift from busy, broke, and broken to time free and cash confident, or you just want to continue with the exponential growth, check us out at modernchiropracticmarketing.com. Look at the MCM Mastery tab, watch the short video in there, and check out what we are doing now for evidence-informed chiropractors. We are equal parts coaching and marketing done for you. Yes, you shoot some videos, we help you with campaign strategies and ideas and really become a thought leader in your community. You shoot those videos, you send them to us, we produce, edit, and brand them to you. Then we distribute them through all of your channels. We also take them and we turn it into one good blog per month. And every other month, we have Darcy Sullivan producing a robust blog with a topic that you pick from her database to help with your SEO. So we essentially become your content marketing agency to make sure your practice is always having ethical, elegant content marketing to help grow your practice. On the coaching side, we also help you with everything from marketing ideas to business, communications, finances, anything practice growth, and really try to help prevent you from being stuck on that island. And we hold you accountable. We have a great group of doctors that are just doing amazing things, and we look forward to help you out to take that next step in your practice. So again, check us out at modernchiropracticmarketing.com and learn more.